Hello, my name is Lori Gonzalez and my major is Healthcare Administration. Healthcare Administration. I'll be discussing today 3 areas where the U.S. healthcare system is experiencing significant changes in patient participation, healthcare coverage, and delivery of care. China's and Germany's 3 areas in patient participation, healthcare coverage, and delivery of care. Compare and contrast of the U.S., China, and Germany. The ranking systems of U.S., China, and Germany, and the best practices the U.S. healthcare system should integrate to improve patient care, including potential fiscal, regulatory, and/or policy issues. The United States patient participation in their care. The electronic health information contains a patient's medical history, diagnosis, medications, treatment plans, immunization dates, allergies, radiology images, and laboratory and test results. It allows access to evidence-based tools that providers can use to make decisions about a patient's care, preset and streamline provider workflow, and patient participation in their care by digital technology of smartphones, tablets, and web-enabled devices have caused changes in today's communication. Patient participation in their care is important in managing and treating their health conditions such as diabetes, obesity, chronic conditions, and heart conditions. Electronic health records also ensures that providers can give patients full and accurate information about all of their medical evaluations. Providers can also offer follow-up information after an office visit or a hospital stay, such as self-care instructions, reminders for other follow-up care, and links to web resources. It can create an avenue for communication with their patients. With electronic health records, providers can manage appointment schedules electronically and exchange emails with their patients. Quick and easy communication between patients and providers may help providers identify symptoms earlier, and it can position providers to be more proactive by reaching out to patients. Providers can also provide information to their patients through patient portals tied into the electronic health record system. The U.S. healthcare coverage. The uninsured rate among working-age adults rose to 15.5%. The uninsured rate among adults in the states that did not expand Medicaid rose to 21.9%. And in 2019, it is expected people will no longer have to pay for a penalty on their federal tax return if they don't have health insurance. If bipartisan agreement regarding the Affordable Care Act were possible in Congress, there are several policy options available that have the potential to increase health insurance coverage. These include providing financial support for advertising to improve awareness of coverage options in all states, and improving health plan affordability in the individual market and ensuring each market has a participating insurer. Healthcare coverage. In China, supervision by health authorities at a national and local level, and some direct provision through public ownership of hospitals. In Germany, health insurance that insures a national population against the cost of health care. And in the United States, Medicare for 65 years of age and older, and some disabled are included, while Medicaid has a population with low income whose employers do not provide coverage. Employer coverage, state-level insurance exchanges with income-based, subsidized, mandatory insurance coverage by, with some exceptions, of 10.4% of adults that are still uninsured. The public system financing for China. There are 3 main publicly financed health insurance types, with local area risk pooling, urban employer-based, taxes for formerly employed urban residents, basic, and rural cooperative medical scheme. In Germany, the employer/employee embarked payroll tax and the general tax revenue. In the United States, the Medicare payroll tax, premiums, federal tax revenue, Medicaid, federal, state, and state tax revenues. The private insurance roles in China. Complementary to cover cost sharing and gaps, as well as better health care quality and other high reimbursements. No data on coverage, but growth has been rapid. And in Germany, 11% opt out from statutory insurance and buy substitute coverages. Some complementary are minor benefit exclusions from statutory schemes and co-payments, and supplementary coverage, improvement of amenities. In the United States, primary private voluntary insurance covers 66% of the population. It is employer-based and individual. Supplementary for Medicare. The caps on cost sharing. For China, there is none. For Germany, there's 2% of household income and 1% of income for chronically ill. And in the United States, there is, for most private insurance, the plan is $6,600 yearly limit for individuals and $13,200 for families as of 2015. The exemptions and low income protection. In China, government subsidizes to low income families for insurance, contribution and out-of-pocket cost, emergency assistance by local governments for specific diseases, and unpaid emergency departments or other expenses. In Germany, children and adolescents under 18 years of age are exempt. And in the United States, any low-income, Medicaid, older people, and some disabled. In Medicare, the premium subsidized and low-cost sharing for low and middle-income families on the exchange on some affordability exemptions from the insurance mandate. The U.S. delivery of health care enables all citizens to have health care services, delivers health services that are cost-effective and meet pre-established standards of quality. The United States pays more for annual physician visits, C-sections, and medications than any other country. The United States Medicare, Medicaid, government health insurance has tons of people on these insurances, which allows them to have the power to set their own prices. And on the Affordable Care Act, premiums are changing in 2019 due to the lack of federal legislation actions to improve the weakness in the Affordable Care Act. If physicians choose not to accept the Medicare, Medicaid, it is a big loss for these physicians' patient influx in their office. The organization of the health system in China. China's People's Congress and the Central Committee of Communist Party of China, then goes to the State Council, and then drops down to the Ministry of Human, the National Department and Reform Commission, the National Health and Family Planning Commission, the China Food and Drug Administration, the Ministry of Finance, and the Ministry of Education. From here, they drop down to the Urban Employment-Based Health Insurance and Urban Resident Health Insurance, the General Administration of Quality Supervision, Inspection and Quarantines, and National Universities. Then it drops down to the State Administration of Traditional Chinese Medicine, the Rural Newly Cooperative Medical Scheme, and the hospitals. And moving down to provincial governments, Chinese Academy of Medical Science, China's CDC, and the Bureau of Health Politics and Hospital Administration. And lastly, a similar government structure to that at the national level, and then the Department of Health Care and Quality. The Organization of Health Systems in Germany. The Federal State Ministry of Health has supervision and tax subsidized, statutory long-term care insurance, and social course of SHI insured, sickness funds and their associates, Federal Joint Committee, Federal Chambers of Physicians, and then their private health insureds through private health insurances. The Organization of Health Systems in the United States has a public financing and a private financing. The public financing has the federal government and the state government, while the private financing has the privately insured individuals. Looking down on the private financing, it goes into the insured individual, the employer, the marketplace, or the private insurance. Looking at the federal government and state government, these drop down into selected health agencies known as the CDC, NIH, and HRSA, AHRQ, and FDA. The Department of Health and Human Services, the Centers for Medicare and Medicaid Services, the Medicare CHIP, Medicaid and CHIP, and Medicare. Other government insurance programs, and the providers, of course, would be the hospitals, the physicians, the long-term care institutes, the mental health institutes, and the pharmacies. And the last would be non-governmental scientific and professional organizations and provider regulatory organizations. Comparing healthcare systems in China, Germany, and the United States. In China, the central government has overall responsibility for national health legislation, policy, and administration, guided by principle that every citizen is entitled to receive basic healthcare service with local and national governments. In Germany, the health insurance is mandatory for all citizens and permanent residents. The states own most university hospitals, but municipalities own about half of all hospital beds. And in the United States, private insurance is regulated mostly at the state level. The state and federally administered health insurance markets were established to provide additional access to private insurance coverage with income-based premiums subsidized for low and middle-income people. States given the option of participating in a federally subsidized expansion of Medicaid eligibility. Reducing disparities. Reducing disparities in China, Germany, and United States. China's health coverage through publicly financed insurance is now nearly universal, and there are safety nets for the poor. The disparities in access are due mainly to variation in insurance benefits package, urban and rural factors, and income inequalities. To improve benefit packages and reduce disparities, central and local governments intend to consolidate insurance schemes. Central and local governments sponsor trainings for rural doctors in urban hospitals and require new medical graduates to work as residents in rural high facilities. In Germany, the strategies to reduce health disparities are delegated mainly to public health services, and levels at which they are carried out differ among states. The primary preventative care is mandatory by law for sickness funds. Detailed regulations are delegated to the Federal Associates of Sickness Funds, which has developed guidelines regarding need, target groups, and access, as well as procedures and methods. The health minority regulatory conduction studies from the patient and perspective. In the United States, the disparities exist in accessibility and quality of health care in the United States. Federally qualified health centers provide comprehensive primary and preventative care, regardless of their patients' ability to pay. The Medicaid and CHIP provide public health insurance coverage for certain low-income populations, and the subsidized to enable low-income Americans to purchase insurance through the exchange, and efforts to achieve for mental health care and substance abuse services. Ranking systems of the U.S., China, and Germany. In Germany, this principle is a firmly held belief that government is obliged to provide a wide range of social benefits to all citizens, including medical care, old age pensions, unemployment insurance, disability payments, maternity benefits, and other forms of social welfare. Individual health insurance premiums for workers are calculated on the basis of income and not age or the number of dependents. In the United States, health insurance is purchased in the private marketplace or provided by the governments to certain groups, and health insurance plans have unrestricted choice of health care providers. The third being China. In developed urban area, patients may visit well-known experts, but still there are 2A hospitals with less advanced equipment than a 3A hospital. China may be one of the minorities who still have no rational residency and specialist training programs when looking around the world. The best practice the U.S. healthcare system should integrate to improve patient care yearly is performance improvements in keeping the patient safe, matching care to science, and avoid overuse of ineffective care and underuse of effective care. The education awareness, free available resources which give basic explanation of medicine principles, data and outcomes for quality improvements in the U.S. healthcare, medical errors, healthcare costs, strategies for methods of medicine, and being patient-centered by honoring the individual, respecting their choices, their time, and their racial equality. This concludes my presentation. Thank you for listening.